Oh, in the
Within it, just yeah.
yeah. Which slide? Okay.
Yeah, y'all eat y'all lunch first. Now, is it? Yeah.
Okay.
Now, is it?
As critically ill patients
So that's
fight
it.
infectious insults, there is often
So
an
it's gonna
excessive
do that.
response
They
that
can hear it?
results in the syndrome of severe sepsis.
They should.
Clinically,
Okay.
you may see increases in temperature,
able to.
heart rate,
And
respiratory
they
rate,
can see the
and
video
abnormalities
too.
of white blood cell count or
Yeah.
differential. As the disease progresses,
I'm
blood
sorry if
pressure
I'm
may drop
redundant,
with
but
No,
this-
not at all. It should. It looks like it is. So everybody starts rolling in.
I appreciate it, man. It's
Yeah, we did, quite a few.
Yeah.
But are you, who's charging this weekend, by the way?
This weekend, it might be Kelly.
Kelly?
Yeah. This
I'm on three, no?
Tuesday, she took over Tuesday, so it'll either be Kate from South. That's when we just put names on the list. Yeah.
Health experts gathered in Washington today to talk strategy in the battle against sepsis. Sepsis kills more than 250,000 Americans every year, making it the third leading cause of death behind heart disease and cancer. Anita Nair has one family story.
When 12-year-old Rory Staunton died, his parents, Kieran and Orla, had no idea what happened. Rory had been a healthy kid until he got injured in gym class. So what happened at school?
He fell and scraped his arm, dumping for a ball.
See,
About
Dan,
24 hours
this-
later, he started feeling
this
sick.
doesn't have a
His
soundboard.
parents took him to the hospital where he was misdiagnosed with the flu.
Yeah, so
3 days
that's like,
later.
if it was the HDMI, that would be the best, but that wasn't working for some reason. So this one, it should. Oh, let me try something.
Oh, I want the soundboard to hear.
Oh, yeah, there we go. Okay, check something.
This is sound. This is
Yeah,
sound.
it should be, but
Associate Chief Medical Officer.
yeah. It's not coming overhead.
Why we need to be as aggressive
Let
as
me
we
try
are.
something
Does
again.
knowing how these regulations and health are the easier?
Very good chapter. We never what I think makes us very angry is that more economy.
HDMI.
So they can't hear me out there.
They will hear us. I don't know if they'll hear the video as well. They should if the way it's like this. But like here, we won't hear everything. We'll only hear what's from here.
I have speakers. They won't hear me online. Will
They'll hear us online.
Word.
Yeah, that's that'll actually help. Are you able to hear out there? Just
Yep, I can hear.
perfect. Thank you. All right, so they can hear as well. Oh, right here.
So the sound, can you hear me over? Or they'll be
Correct. They,
When 12-year-old Rory Staunton died, his parents, Kieran and Orla, had no idea what happened.
So they
Rory
can
had
hear
been a
us online,
healthy
okay.
kid until he got injured in gym class. So what happened at school?
I try to, put a little spice in there, but sometimes it just. This, do they pre-check this room?
Pre-check the room?
Yeah.
no, we've asked them to fix this like over months ago.
No,
Yeah, it's a joke that hasn't been.
But they'll be able to hear me online, okay?
Correct. Yeah.
Oh, okay.
Dr. Crash let us know that they're able to hear us.
Appreciate it. Man. Yeah, can they hear over? They think they hear
Correct.
online?
Yep.
Okay.
They can hear us online.
Last time I went over, so I need all the time.
Exactly. Good afternoon, everybody. We're going to get started. We got Dr. Rivers here to help us talk about sepsis. I know he's got a lot of slides, so we're going to start so that we can try to get through as much as we can.
Thanks, Dan. Did you know the concept of sepsis is a broad area? And I'm thankful that he gave me 2 hours because we'll use every bit of it. And he had to pull a hook on me last time, so I have to move a little faster. But it's a pleasure to speak. First, I want to just have no disclosures to make. If you notice the slide here, it's kind of a cartoon, makes fun of advertisement, but I have no disclosures to make. And the one disclosure I have to make is that I'm what we call measure steward for the National Sepsis Measure. So that's what we call the CMS measure that y'all probably cuss at me every time comes up, your BPAs and all that stuff. But we've been at this since 2008, and Henry Ford Hospital is the National Sepsis Steward. So that's actually something good. I also want to tell the audience that we have a couple of things coming up in the next week. Every year, September 13th is called Sepsis Day. So internationally, if you go online and you type in World Sepsis Day, almost every country in the world has some form of a sepsis celebration. Now, they may do different things, they have different lectures and what have you, but that is every 13th of September, and that's next week. In addition, the Sepsis Alliance, which started in 2006, is an alliance started by a dentist whose daughter went and had a hemorrhoid operation, and she went into septic shock when she got home. It was an outpatient procedure. So since that time, he took it upon himself to create what we call a consumer-based sepsis organization, which is called the Sepsis Alliance. And they're having a 2-day symposium next week, the 14th and 16th, and it's going to go over some broad topics of sepsis and in more of a consumer standpoint. So I think you'll enjoy if you have time to look into that. I also want to thank the sepsis program here. We've had it going since 2010 or something like that, or even earlier. And even my research coordinators help out with our sepsis program. And then Dr. Jay Prakash is our system sepsis chairperson. So over all the hospitals in the system, she's head of the sepsis committee. So appreciate all her efforts, and she'll do internal medicine grand rounds actually next Thursday in celebration of the sepsis week as well. So this is the 20th anniversary of early goal-directed therapy. How many of you heard of that? Problem is if you look at the date on there, that's 2001. So you're probably in the kindergarten or something like that when this article came out. So, but it's a good time to be able to reflect back on the history of it. And now what I'll do is take you through kind of a history of how it happened, and then go through the basic concepts of where we are in terms of sepsis care. Now, this is Henry Ford, who actually started this hospital. This is George Washington Carver, and two of their best quotes that I found is that he said, "Excellence is formed in common things and uncommon places." So when you look at the background, I'm an emergency physician and I did critical care. And one of the things I came back from fellowship is I was confronted with an ED that's like ours. And when I looked at the care in that ED, noticed that the patients were on Levophed 40 mics when I did my shift, and they were on 40 mics the next day with a liter of fluid in between. I knew that that wasn't right. So what it is that it presented an opportunity to do some common things we take for granted in an ICU, to do it in an ED setting. And that's really the nature of what we call early goal-directed therapy. And Henry Ford said, when everything seems to be going against you, remember the airplane takes off against the wind, not with it. So there was resistance to a lot of this because people don't like change. What I want to do is educate you so that you have the physiology to understand. And then when you look at replications of goal-directed therapy, you'll be able to say that I can interpret these articles with this physiology in mind. And I want you to stop me at any time for any questions, because I'm gonna move pretty fast. So what we're gonna start off with is the sepsis diagnosis, SIRS versus QSOFA. In addition, talk about the history of the sepsis measure, and then the 3-hour components of the sepsis bundle, which includes cultures, antibiotics, source control, risk stratification, and why you check that lactate. We'll go through the literature as far as why we do that. And then when we get to the 6-hour portion, that's the shock portion, we'll talk about controversies in fluid therapy, a little bit about vasopressor use, then the perfusion assessment, and then a quick overview of tools of perfusion assessment, a little bit about steroids, and then outcomes. We had a recent article just published in Chest this month about the whole sepsis measure, about 1 million patients in that study, and I'll build some of that as well. And then we'll talk about some of the current research we're doing with pulmonary critical care involving fluid management, Tylenol versus vitamin C, and also Euphrates, which is the endotoxin filter. And then Suzanne will come up and give us an epic tour, hopefully 20, 30 minutes about the epic smart phrases and different things you can do with epic to kind of help you out in terms of charting when you get a septic patient. So we got a little work to do here. So the socioeconomic impact, why do they pay attention to sepsis? Well, if you look at the national data and you look at where all the money goes for sepsis, and remember pneumonia is sepsis, and a lot of times only up until the ICD-10 coding that they start to realize that pneumonia is an infection. Somebody's coming up. Are they both? Okay. It just showed up. $33 billion a year and 8.7% of all the aggregate costs in the United States is the #1 cause of ICU admission for elderly, and then the leading cause of hospital mortality. So all the patients' death certificates more commonly will say sepsis than any other diagnosis. And in addition, 1.1 trillion, that's almost 20% of all the medical costs spent here in the United States. So when you look at the cost of sepsis and you say, why do Medicare has a interest, is because they pay 50% of the healthcare bill in the United States. So that's why we see so much activity. And as you all know, the mortality incrementally goes up with each sepsis diagnosis. The sad part is, and I'll end this talk, is that this is not changing a lot. And so what we have to do is realize that we can make an impact, but also we have a lot of work to do. From a morbidity standpoint, if sepsis doesn't kill you, it'll create a lot of disabilities. If you look at the most second common cause of amputations, it's not from cardiovascular or arteriosclerotic disease, it's from sepsis. People get amputated because of pressors and what have you. In addition, chronic lung disease, these people just don't go home. Sepsis is just like COVID. They have long-term disabilities. They go to LTACs, they get trach, they get, Lord knows, all kind of respiratory issues. So when they leave here, they just don't go back to work. And 30% of septic patients will be treated for some kind of psychiatric disorder within a year after discharge, whether it's depression, which is the most common, but they have a sundry of what we call psychiatric disorders. And then chronic heart failure, as you know, septic patients are sick before they get septic. So they go back home with their pulmonary hypertension, COPD, EF at 30%, and they come right back sometimes. So this doesn't go away. But there's also a sepsis-induced cardiomyopathy that's separate from your underlying disease, and this also needs to be factored in. And then 30% of your septic patients will go on dialysis, which you probably know, pretty familiar. You know, the good thing about it is they come back 6 months later. 50% of these kidneys do come back if it's acute or ATN. So that's the good thing. But they do go home on dialysis. And then neuromuscular disorders. We give these patients sedation, paralytics, etc. They lay in bed for long periods of time, and they don't have a lot of activity of their muscles, so they atrophy. And that has long-term consequences in terms of what we call the critical care myopathy that can be a sequelae of our septic patients. And if you look at 30 days when you discharge a patient, they may not come back to you or to this ED, but they'll come back. And they usually 30% of patients discharge with septic shock, usually we get readmitted. You know, I'm sure you probably see that yourself, but the whole idea is a common cause of hospital readmissions. And this is actually a big focus of sepsis now, is how can we make sure we send these people home correctly, because we don't really check duration of antibiotics, maybe some markers like procalcitonin or other things that may help us. So we do make a clinical judgment on the floors, sending these people home when they actually probably should be staying a little longer. But hopefully we'll get better at that, but that's one of the current focuses of early sepsis care. So this slide is an old slide, but it hasn't changed in 20 years because definition hasn't changed. And we'll go through a little bit about the controversy, but in general, a septic patient starts with microorganisms that create what we call a systemic inflammatory response syndrome. Now, this is a clinical constellation of 2 or more of these criteria. So either febrile, hypothermic, tachycardic, tachypneic, white counts usually higher, low, or isolated bandemia, or you have a respiratory alkalosis. So 2 or more says you have SIRS. Now, the key point is you can walk up a flight of stairs and get it. So it doesn't mean that you're infected, but it does mean that there's something going on. Now, sometimes you don't need a lot of SIRS. You just need something like this. A lot shaky. I'm sure that helps you out, but a lot of people spend a lot of time on definitions, but if you see pus, you don't need all that. And if you look at a lot of these definitions, we spend a lot of time arguing about them, but it's quite obvious when you go in a room that these people are septic. But in general, what you have to have is a quote unquote suspected source. And then there's what we call a inflammatory response that occurs that separates what we call sepsis from severe disease. Now, this patient had an abscess in that axilla that had pus in there. So what you can do is you can open that up, IND it, pack it, put that patient on Keflex and send them home. That's what we do a lot of times. So what separates that patient who has a resolution of local inflammation from a patient that goes on to sepsis? Well, it's insufficient pathogen elimination. Pockets of pus sitting up in that axilla start to stimulate an inflammatory response, both cellular and humoral. And subsequently, the body starts to react to that overflow of inflammatory activity. And now you start to see what we call the sequelae of sepsis. And so the progression of sepsis, based on the fact that the patients have what we call incomplete resolution of local infection, means they go on to have systemic responses. And that includes endothelium, the microcirculation. And then when it starts to have organ effects, where that creatinine goes from 1 to 2, or that INR goes up a couple seconds, that's now what we call organ dysfunction, and that's severe sepsis. The key point is a lot of people go on with severe sepsis and we don't see it because they look okay. But when we check some labs and we notice the creatinine's up or the lactate's up, and then we say, oh, we're in trouble, we're actually going down a path that's probably going a little faster than we think. Because the evil transition occurs a lot of times when we send them to the floors or perhaps send them out too early. And what's missed is the progression of the cardiovascular part of sepsis, which is really the part that causes septic shock. And this is what kills them. And the irrecognition of this pretty much has created a lot of mortality, but it's also been a reason why we've been more successful because we catch these people much earlier. So when somebody calls you from the floor, that lactate's 2.3, you say, why are you calling me? That's the reason. It's because we now have a screen, for good or for bad, that tells us that these people are getting sick much earlier, and that's why the mortality is going down. So remember that, because we'll revisit that in a second. Now, the key point is that sepsis is no longer an ICU disease. When I was a resident here, we had 9 beds in our MICU. 9 beds, could you believe that? So if you think you got it bad right now, you fight over, you pick and choose 9 beds, you're gonna be sending a lot of people to the floors. And on F2, we used to put people on dopamine. We used to allow 5 mics of dopamine on F2. So it goes to show you what we used to do in the past, simply because we didn't have the resources. So what happened is that we finally said, let's make sepsis a hospital-wide disease. Said these people are no longer just ICU patients, they're ED, outpatient, nursing homes, come from home, general practice floors, operating in recovery room. And so when you open up the whole hospital to the concept that sepsis can be anywhere, that's when you really start to make an impact. And that's really the transition we made. And people call it goal-directed therapy, but in general, what we did is just said, let's get better at early diagnosis and treatment, and then go outside the ICU and enable. Now, if you look at sepsis years ago, everybody was into the inflammatory part. So if I got up here and showed you this slide, I looked all smart and everything and said, oh, well, sepsis creates inflammatory mediators and CD4 receptors, and we look at TNF alpha. Then we look at antithrombin, toll-like receptors, which precursors to other mediators, and then platelet activating factors, leukotrienes, look very smart. Activated protein C was a substance that was actually approved by the FDA, and it was New England Journal of Medicine 2001. And it actually was used across the country in large amounts and actually had a mortality reduction of about 6%. So over the course of time, they repeated a trial called a shock trial, and it showed that APC, or activated protein C, didn't make a difference. But the care of septic patients had got so much better that the treatment effect had narrowed, so they took the drug off the market. So the last immunomodulator that we ever used for sepsis, short of steroids, was APC. And sadly, I think it's a perfect drug for COVID because it has properties of anticoagulation similar to heparin. It has local microcirculatory effects in terms of improving microcirculatory function, and it has anti-inflammatory properties. But it's off the market simply because smart people said it didn't work. But I still have hopes that perhaps it may resurrect. But nevertheless, this is how many trials that were done with anti-inflammatory mediators. And right now we almost have nothing short of steroids. And so this is kind of where we were. And with Dr. Roger Bone was an idol of mine who basically did a lot of the sepsis research early. And then one of the things he showed in a study he published in New England with giving Cymedrol 250 milligrams every 6 hours to septic shock. He said that in 1987, that it didn't work, number one, but then number two, early identification and aggressive treatment of patients did result in a survival rate in the placebo group, almost better than the treatment group. So he recognized that back then that perhaps it was the care we were providing early that may make a difference. And then you just look at the date here, that's 1987. You weren't born then, so you just have to believe me. And what he surmised is that perhaps sepsis is a temporal disease where you go through a period of excessive inflammation and then immunosuppression. And then based on your clinical presentation as well as shock state that characterize your sepsis. Now the key is when you spend 12 hours in the ER or 24 hours in the ER and you're giving somebody a magical drug that was supposed to be in an ICU, then no wonder you don't see clinical trials working. And I think the failure of a lot of these studies designs is because their timing was off. And here you're given a drug when the cat's out of the bag, so to speak, that it should have been given within the first 6 hours. And I think we failed in our understanding of the pathogenesis of sepsis. But it's not too late because one of you are going to go out and change that, I'm sure. So we hopefully will see that. But let's fast forward. Remember, it was 1987. So what did he say in 1992? This includes trials. You should have what we call a resuscitation protocol. That includes antibiotics, fluids, vasoactive drug therapy, and nutritional therapy. Now, does that sound like goal-directed therapy a little bit? You remember this was in 1995. And then you say, okay, well, what was it like in 1997? Because after fellowship, I started to think about Roger Bone and said, maybe we ought to go back and look at early sepsis care. So by the time I started looking at it and doing research in the area, this is what this landscape looked like. That's early sepsis care. But the key point in this is that there was no early sepsis care, no surge criteria, no risk stratification. So when you look at lactates, we didn't start checking lactates until 2000. So when you look at lactate and you say, why are we checking lactates? I will go through that, but we didn't even check lactate. Antibiotic recommendations, resuscitation standards, fluid therapy, mean pressure endpoints, myocardial dysfunction, even ultrasound, not in existence. And there was no quality assurance measures, no surviving sepsis campaign, and then no CMS measure. So when you look at 1997, there was nothing. And so when you do understand sepsis a little bit and you realize you go down to the ED or somewhere, people weren't doing anything. But as soon as you start to put stuff together, then that's when they start making noise. Because this is what we understood back in the early 2000s is that ERs were crowded and not well, not very functional. This is our ED back. the early 90s. And Cat 1 was 6 beds. And then you go and you say, okay, we remodeled it in 1990 or something like that. And we remodeled it, and now our Cat 1 is beautiful, but look at the patient population.
So for those you mentioned, like a lot of
So when you look at your patients come up in septic shock and they've been, this is what they, so when you think about it, it hasn't changed a whole lot. Because the volumes are up, as you know, with COVID, it's even more terrible. So when you look at how people are processed in the early phases of sepsis, it's not changed. And so the key point is that you have to have some form of emphasis in order to make change, and that has to occur through some systematic changes and also through public changes, and we'll talk about that. This is a common theme, and this was as late as 2018. This is something you probably know already. Within a few days, you notice that there's a significant relationship with mortality and how the system gets backed up. So no matter what, the crowding is a significant impact on our mortality. So when you look at sepsis and you say, okay, we got to break it down and go back and look at the basics, why don't we start where the patients come from? They come in ambulances, 75% of the time they come in EDs. And it's about 145 million ED visits a year, and about 3% are patients with sepsis. So that's about 1.6 million a year. And the average waiting time is about 5 to 6 hours. And then you say, well, what is the impact of being in the ED? A patient in the ED for 6 hours or more will increase their mortality by 10% in septic shock. So when you look at what the impact is on outcome, it's not good. And then you say, well, what if I make a mistake and send a patient to the floor and then they end up in the ICU? Well, that costs you about another 10, 12% mortality, because people who crash on the floors, they do worse because they get treated later. And people who get it was actually a study out of Henry Ford where they looked at Sepsis Alert, or they looked at rapid response activation. If you went to a rapid response and said the patient's okay, I'll leave them on the floor. You got called back at the second time, the mortality went up 12%. And sometimes we're not perfect, and I'm not saying we're doing things wrong, but that's the price you pay if you don't appropriately assess a patient. So appropriate risk stratification is always key. And even when they get in an ICU, we did a quality initiative. We saw people not getting their fluids or not getting actively treated in ICU settings. So it's not just a ED problem, it's all over the hospital. So it's important to understand that the first quality initiatives means that you look at yourself, you look at your practice, and you see if you're performing the way you should be. So we had other comparisons. We had stroke, which comes out every couple of years, guidelines. Acute myocardial infarction, patient goes to that cath lab. And when you look at trauma, there's no study to show that the golden hour of trauma has ever been validated, but that's how we practice, because we know that the earlier you kind of figure out how severe the patient is and get them to the operating room, the better they do. But when you look at sepsis and you look at how many people present with sepsis and what the relative mortality, we were practicing other diseases at much better efficiencies than sepsis. And so it tells you we had a long way to go. And it also had to be a paradigm shift to change outcomes. So when you go back to that landscape and you say goal-directed therapy, people don't realize that it was a verb, not a noun. And when you say that, you say, well, what's the difference? Well, I had to go look it up because I didn't know the difference. But the difference is that it's a series of actions. It's not just one thing. You got to recognize the patient. You got to label it so everybody has the same terminology. And then you got to act upon it using best evidence, which is always going to change, but you apply the best evidence, and that includes early antibiotics and microbials. And then you want to risk stratify. Who are those patients that's most likely to crash and burn? Because if you pick those people up, the blue alerts go down. Then you have a lot more time to assess, and then you can figure out what are you doing better or what are you doing worse through a good quality assurance. So when you look at the whole idea of goal-directed, it was meant to be a quality initiative and it meant to be a series of actions, but people get up They got caught up in the drama because it was quite controversial in terms of resuscitation. But in general, you know, the truth is that it's a series of actions. And so when you look at the mortality across the board in the nation from the goal-directed study in 2001, you can see the mortality went down. And it went down because of some series of things. Yes, the study, and there was 3 studies, Process, Horizon, Promise, which quote unquote replicated goal-directed therapy study, but what they did is they actually confirmed it in a different way. Because what they did is they, number one, Medicare saw that our national mortality has gone down in a period of time. But all of these studies elevated standards of care. So in order to get in these trials, you had to have SERS, cultures, antibiotics. You had to have a lactate. They didn't say that, but you had to have a lactate screen. Fluid challenge before enrollment, reassessment. It was unblinded. When we did our study, the patients in the ED were there for the study, and they were randomized to goal-directed versus control, and the ICUs did not know the randomization order. You took them, there was no epic, you couldn't go on the computer, figure out what happened to them. So we just took care of them, truly blinded study. But when you look at the first 3 studies, Process, Horizon, Promise, they took the patients from the ER, it was open, and they basically took them to the ICU, so they didn't perform in the ER. So when you got an intensivist and you got a resident and a fellow taking care of the patient for the first 6 hours, the patient's gonna do pretty good, right? And they're gonna have lower mortality. So when you look at study design, that is how the studies were designed. But nevertheless, people who had common sense realize that if you do this to the patients and this is your baseline care, you're gonna have lower mortalities, and overall it's the right thing to do for patients. So the controversy really was very short-lived simply because people know that the care was better. And so when organizations like the National Quality Forum, which is a clearinghouse for all your quality measures, sure, things like CAUTI and all that kind of stuff you don't want to hear, but that's where all that comes from. They basically approved it in 2008, and then subsequently through CMS and also through what I think is a public relations move by somebody who died from sepsis, we saw it take on a huge.
Health experts gathered in Washington today to talk strategy in the battle against sepsis. Sepsis kills more than 250,000 Americans every year, making it the 3rd leading cause of death behind heart disease.
As one family story. When 12-year-old Rory Staunton died, his parents, Kieran and Orla, had no idea what happened. Rory had been a healthy kid until he got injured in gym class. But what happened at school?
He fell and scraped his arm, jumping for a ball. About 24 hours later, he started feeling sick.
His parents took him to the hospital where he was misdiagnosed with the flu. 3 days later, Rory died.
Our son was dead before we heard the sepsis.
Sepsis is a condition triggered by an infection entering a person's bloodstream. In Rory's case, after he scraped his arm. The immune system has an overly aggressive response that can lead to organ failure. Today, the Stauntons held a national symposium on sepsis. They've already helped change the law for New York hospitals, where doctors are now required to use a checklist to rule out the condition. At the North Shore LIJ health system, the rate of sepsis has dropped by roughly 50%. Dr. Martin Dorfler is the Associate Chief Medical Officer.
It can move quite quickly. The data says that from the point of recognition, every hour delay increases the risk of mortality. And that's really why we need to be as aggressive as we are.
Does knowing how these regulations affect other people, does it make it any easier?
Very much, we never understood. One of the things makes us very angry is that we couldn't say.
The Stauntons say their greatest regret is not knowing about sepsis. Now their mission is to make sure other families do. Vanita Nair, CBS News.
So this family knew the Senator Harkin, who's the Senate Appropriations Committee for CMS, who funds CMS. They had a hearing, and then CMS had a measure here. So when you look at a lot of the healthcare strides, we are doing the right thing, but sometimes that extra push is political. Political in the sense that we now have a uniform sepsis measure. But that's how it got across. And it's nice to know kind of the history. So getting to our sepsis measure, what we have is some ingredients. And these ingredients include, number one, check a lactate if you see SIRS and suspect infection. Remember, a lot of people complain, everybody has SIRS, but remember, you suspect infection, use your clinical judgment. Appropriate cultures, as well as antibiotics, broad spectrum antibiotics, and a patient should have a fluid challenge if they're hypotensive or lactate greater than 4. It's important that you understand that these are the criteria for fluid of 30 cc's per kg. If the patient has a lactate of 2.5, it's your clinical judgment to give them whatever fluid you want. They don't have to get 30 cc's per kg. Only a lactate greater than 4 or hypotension. And that's probably one of the most misinterpreted parts of the measure, but it's important to understand so that you don't worry about giving fluids to everybody. And if you're persistently hypotensive, pressures to a mean of 65, and you want a perfusion assessment within 6 hours, and this can be anywhere from invasive to non-invasive monitoring to allow hospitals large and small to have a perfusion assessment. And then you want to repeat your lactate. So when you look at what's required or not required, but what's recommended, this is the sepsis measure. Now we do things beyond that, which we'll talk about a little later, but the idea, this is our expectations, and I'll go through the literature of why these are important. Getting back to Roger Bone in 1991, he said that we don't have a label for sepsis. So if somebody came in and they called you and they say a patient's on the floor with altered mental status, really the only thing that made you think about sepsis, perhaps if they had a temp of 39.7 or something. But a lot of these patients have what we call ill-described symptoms. So he said that let's have a terminology that makes us think sepsis, like chest pain, MI. So what he did is he came up with the idea based on the fact that we were just all over the place in terms of how we would come up with the definition of sepsis. And he said that we were practicing insanity because the cardiologist, if you had chest pain in the EKG and a troponin, they took you to the cath lab. He said, why do ICU intensivists or emergency physicians, why do they argue about sepsis so much? Because they didn't have a label. And so that's why we have SIRS. And we did a study back in the early 90s, and we never published the data, but Dr. Andrew Bissonette actually published this data, and it's old data, but we published it simply because we wanted people to understand that we looked at it years ago, that sepsis criteria correlated with length of hospital stay, ED length of stay. Your cost was higher, and when you got inpatient, the costs were higher and you stayed longer. So SIRS, even though it's non-specific, it tells you that something's wrong with you. And the key point is you take the next step and you go through the process of saying, is this infection or not? And this also carries some significance in terms of documentation. If you look at a patient with pneumonia and a creatinine of 4.2, is that patient SIRS, sepsis, severe sepsis, or septic shock? Yes, severe sepsis. What does that make a difference? Well, number one, if you put severe sepsis as your primary diagnosis and that patient goes to the floor, they're more likely to get their antibiotics sooner and they're more likely to get their fluid challenge sooner. So the whole idea is that the term of being consistent changes management later, because somebody's going to look at that floor and say, or that chart and say, this patient's doesn't look like pneumonia, this patient's severe sepsis. And then if you look at costs, Katrina, which does a lot of our rejections for our insurance companies, they reject, 30% of our patients' bills because we don't code them correctly, or we don't put the diagnosis. So here you put that patient with pneumonia, and then you just change it to sepsis or severe sepsis, your reimbursement goes up almost 2 or 3-fold. So the idea is that we should be consistent. These terms are not just, terms we're throwing around. The insurance companies now use them to bill. We'll talk about SEP3 definitions. That is the nature of what we're dealing with. And so it brings us to sepsis definitions, SEP 3. This was the most tweeted medical publication in history. Simply because there was tweeting available. The article came out of New England Journal in 2001. Nobody said much because there was no social media. It just tells you. But this ended up being a huge controversy, and it still remains. But let's go through this a little bit. Now, you're going to have to know this QSOFA, or the SOFA score, is comprised of, as you can see, 5 components based on oxygenation, platelets, bilirubin, hypotension, your mental status, and your kidney function. Now, they wanted to come up with something that could replace SIRS, so they basically came up with QSOFA, which basically says hypotension, altered mental status, and tachypnea. And this said this, and it was proposed that this could replace SIRS. So this is kind of what the article in JAMA summarized it as.
Sepsis is a life-threatening clinical syndrome that develops when the body's response to infection injures its own tissues and organs. Clinical criteria for diagnosing sepsis were first proposed in 1991 and last updated in 2001, but a lot has happened since. So now, a task force of critical care, infectious disease, surgical and pulmonary specialists has published the 3rd international consensus definitions for sepsis and septic shock that take advantage of advances in the science of sepsis and the ability to test proposed sepsis criteria against patient outcomes using electronic health records data. The group defines sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. In clinical terms, patients with sepsis have suspected or documented infection and an acute change in the sepsis-related organ failure assessment, or SOFA score, of greater than or equal to 2. The group recommends use of a bedside score, the quick SOFA or Q-SOFA score, comprising an increased respiratory rate, alterations in cognition, and low blood pressure, to identify patients outside critical care settings with suspected infection likely to have poor outcomes typical of sepsis. Finally, they define septic shock as sepsis with abnormalities in circulatory physiology and cellular metabolism in the absence of hypovolemia, profound enough to increase mortality. The authors acknowledge that there is no reference standard for diagnosing sepsis, and that the definition of sepsis is and should remain a work in progress.
So the key is, what do you do today? Well, today, the ramifications of changing severe sepsis, severe sepsis, and septic shock, traditional definition, and if you look at SEP 3, it'll eliminate severe sepsis. And the problem with that is that you're basically gonna statistically eliminate people who will still exist, but it's based on a large database, crunching data and what have you. And what's interesting is that that lactate greater than 2 will also eliminate 30% of septic shock patients, because there's alactemic septic shock. You ever seen a patient on Levophed with a normal lactate? That patient's not in shock anymore. Just throw them out. They don't exist. So this is the problem when you do large database analysis and mega data, is that you start to come up with stuff that don't even make sense, but it got in JAMA. But to understand the pathogenesis of the disease and really what they're doing, I think that that's what allows you to interpret this data better. Now, this study came out in CHEST, and it actually examined through meta-analysis what's best suited for SIRS as well as QSOFA. And they found that QSOFA is a better mortality predictor. But when you get a patient and they call you in an acute situation and the patient needs to be treated, what do you want the mortality? Why do you care? You know the patient's not DNR, you take care of the patient, you do what you gotta do. So mortality predictor, okay, fine. But when it comes to diagnosing sepsis, really what you want to do, because you want to have a broad net, pick up the people, and perhaps those who are not septic, let them go. But the whole idea is that that's the purpose of a screening exam, is that you want it to pick up the disease. So if you look at the current recommendations, that SIRS, even though more sensitive, is superior to SOFA, and the recommendations from Surviving Sepsis et al. Is to say, continue to use SIRS. Any questions about that? This trial came out a couple of years ago that kind of shook up critical care a little bit, because it basically said that even in ICU situations, you can resuscitate a patient looking at capillary refill and lactate. That's it. And so it basically, even though through sub-analysis and what have you, it's turned out to be not true, it made the clinical exam relevant again. And so when you look at the physical exam, it does mean something to go in and look at your patient and examine your patient. Postural hypotension, specificity 81%. Just telling the patient to open up their mouth and stick out their tongue, that's very sensitive. And then mental status changes are not totally bad, but it can be confusing because a lot of people can have altered mental status. But look how specific capillary refill is. So when you think about it, we tend to want to say, okay, let's do ultrasound, put in some lines and stuff, but just a quick exam can help you in terms of picking up how sick that patient is. A normal capillary refill should be less than 3.5 seconds. And if you look at modeling, which is one of my favorites, is that you look at the kneecaps. If they're modeled, you're in trouble. And this is an example of what hemodynamically this patient looks like who's modeled. And then we happen to have monitoring in the patient. Sorry, this patient was modeled, but also had high lactate, and I'll come back to that. But this idea of modeling score was promulgated in an article 2 or 3 years ago that basically carried a score 1 through 5 for the circumferential involvement of the extremity outside the kneecap. And they actually showed that the modeling score correlated with urine output, arterial lactate, cardiac index, and SOFA score, and mortality. So just going in a room and seeing modeling everywhere is relevant, because you should be getting a little nervous and perhaps pushing things along a little bit. So it does add to your score, and it also adds to your clinical exam. So when you look at the perfusion assessment, which you can do as a substitute, so this equates to a PA catheter, by the way, just for the CMS measure, not for clinical. You obviously should do what you got to do. But the whole idea is that the clinical exam can be a substitute as one of your options, and it's relevant to do it. So antibiotics, this is the first 17,000 patients from the Surviving Sepsis campaign, which they looked at time to antibiotics and they looked at mortality. What they found is that patients who get their antibiotics within 6 hours have a benefit of, or not a benefit, but 8.5% increase in mortality. So delayed antibiotics, not good, and as you well know. Recent study just published in Chest, and this is over 10,000 patients, showed that short time of antibiotic administration not only affected hospital mortality, but 30-day, 90-day, 1-year mortality, which I thought was pretty astounding. That you were walking around a year from now because somebody got your antibiotics in within 3 hours. That's pretty impressive. And then patients who go from severe sepsis to septic shock, you actually stop the progression of septic shock by giving antibiotics quicker. So that fluid challenge is important, but that antibiotics may keep you from going into septic shock. So that's another resource that perhaps you can take advantage of. And why don't we get those blood cultures? Well, a study by Anand Kumar, this is about 4,700 patients, where he looked at patients who got blood cultures, and he looked at the cultures that came back 24 to 48 hours later, and he looked at correctness. He found that whether you had gram-negative bacilli, gram-positive cocci, anaerobes, or yeast, if you did not hit that antibiotic correctly on the first time, you had a 5-fold increase in mortality. The good thing about it is, what do you think your correctness rate is? You look at antibiotic correctness. Give yourself a pat on the back. It's about 90, yeah, it's about 90, 95, 92, 93%. The key point is, what do you order? Sapropine, Banco. you may throw some Zosyn in there every now and then. But the whole point is that combination covers almost everything. What you do miss is you miss the Candida, the fungus, and the weird stuff like Legionella, which you have to think about. So that particular patient, if it got some weird stuff going on, transplant patient or something like that, that's where you start to get a little more elegant in terms of your antibiotic administration. But those are the people that we get in trouble with, is those complex patients. But in general, we do a good job. Now, ID will tell us that we're killing people with antibiotics. You got an ID fellow in here, ID crew in here. But and so this is huge. I mean, they're going through antibiotic stewardship, which I think is correct. But I think we do a good job, but you can do better by following what we call the tenets of antibiotic stewardship, and that's initiate. That one dose that you give and the patient comes in septic shock, nothing wrong with that. But what you got to do is evaluate the cultures and look at the progression. If you see there's no documentation for continued need of antibiotics or the de-escalation, that's when you act and stop. And so the whole idea is not that we're doing a bad job with antibiotics, because the net overall incidence of community-acquired C. difficile has gone down. ESBL, community-acquired ESBL is going up, but hospital-acquired ESBL is going down. That's because we're getting better. So it's not to say the end of the world, but the idea is that we can do better by following the tenets. So if you see something like this, something like that, something like that, get your flu shot. Just kidding. That's not the flu shot. Or you got a lady like this, who they had one at West Bloomfield actually not too long ago, who came in with flank pain, fever, put on Levophed, sent to the unit, and basically was up there for a few hours until they realized that she had that. And then this is kind of a
Nearly 2 years ago, I lost all 4 limbs as a result of sepsis as a complication of a kidney stone that I had. 2 years ago, amputations began, and that's when everything changed. And I had to begin looking for another advantage in life, which would be prosthetics. My quality of life is going to be different.
So this lady ended up having, obviously, pyelonephritis, but she also had a septic stone. And if you're talking about something that causes ARDS, you get a bad septic stone and shock, they'll just wipe their lungs out. And what's interesting is that her treatment is fairly simple. You take the catheter, you stick it up in her bladder, you go through her ureter, and you basically decompress that kidney. And this can be done either through a perc or through a endoscopically done. And what you see coming out of that ureter is this. What's that? That's pus. It's like pus was coming from that axilla. That's a column of pus sitting on top of that kidney stone. And so just that decompression takes the organ failure as well as the ARDS away. And that's how important source control is. So when you look at source control, we call it the 4 Ds: drainage, debridement, device removal, definitive measures. That ultrasound you got, there's been studies to show that ultrasound improves the time of diagnosis of septic shock, because you can scan the patient and perhaps come up with a dead gallbladder or something. That actually enhances your ability to come up with a diagnosis. CT scan, make sure it's read correctly. Foreign body, dialysis catheter, chemo device. If it's got pus coming out of it, you gotta take it out. Don't wait till the next morning. The patient's on Levophed and you got pus coming. No, this gotta come out. So we have to recognize you gotta bother people, but it's gotta come out. When you talk about operative intervention, in the last couple of weeks, we had 2 perforated colons in somebody under 40 years old that came in septic shock. And what that means is that you got to get them to the OR quick. And so time to delay, 2.4% increase in mortality for every hour delay in a patient comes in with a viscous that causes shock. So surgeons push them, tell them to get, obviously you do your resuscitation, but tell them to get them out of here. You can't do nothing to them. They need to be operated. Any questions so far? I'm moving fast because I don't want you don't pull that hook on me. So the next thing is that go back to Roger Bone in 1992 and said, see what he said with SIRS. He said SIRS with various etiologies should be combined with risk stratification or probability estimation technique. So when you come in with chest pain, you get an EKG, you get a troponin. And you look at all these things together to make a definition. And so when you look at sepsis, SIRS, nothing wrong with SIRS, but we needed a risk stratification tool. And that's why the concept of lactate came about. Now, why do we check a lactate is because if you look at the definition of severe going from severe sepsis to septic shock, mortality goes up about 26%. And if you look at the definition, systolic less than 90 or 40 millimeters of mercury less than your walk around blood pressure. So if you're 190 over 100, you come in, you're 120 over 80, that could be shock to some people. But you wouldn't know it unless you have a parameter. And that parameter is reflected by the fact that blood pressure equals systemic vascular resistance times cardiac output. So you can decrease your cardiac output, increase your vascular resistance, and your blood pressure actually can remain stable. Now, you can do that for a little while, but eventually it's going to cost you. But the whole idea is that we need a better way to screen our patients. And that's why lactate came about. If you look at how many lactates we did in 1990, we did about 2-3 a week. And now we do about 700 a week. So you look at lactate, and we take for granted that we did not use lactate as a screening test since in the year 2000. That's when it actually started. We started using lactate. So for good or for bad, it's turned out to be a better way to screen our patients. Because lactate reflects some disorders that we don't see with vital signs, and it comes from oxygen transport abnormalities. And I'm gonna just give you a quick primer because it only take 30 seconds. You take oxygen, you put it on hemoglobin, and that's your arterial oxygen content. The cardiac output reflects content, cardiac output, that's your delivery, a liter per minute, average person. We consume about 25%, so the net oxygen returning to the heart is about 250 mils, and subsequently that is reflected in your venous oxygen saturation. So when you look at your venous saturation, which could come from either the central line or the PA catheter, they correlate very well. And so the substitute you can make is that you can check your venous sat off your central line. If that's low, you can do 3 things: give more oxygen blood, or increase your cardiac output, or decrease those consumptive demands by treating stress, pain, hypothermia, shivering, decreasing your work of breathing through early intubation. If the number's normal, most of the time you're going to do okay, but if you combine it with an increase in your lactate and it's high, that can mean dysoxia, and that's not a good thing. So remember, you need multiple variables to help you, but in general, your SpO2 can be helpful in the early stages. Now let's get back to oxygen transport. Now, what's the true definition of shock? It's the inability of your body to meet its oxygen supply and demands. And when you do that, you generate a byproduct of anaerobic metabolism, and that's lactate. So a lactate greater than 4 should never go to the floor. That's how we used to say it. And that's why we pay such particular attention that lactates do help screen those patients who are high likelihood of death. And where do we get that from? It's Dr. Max Harry-Wow, mentor of mine, who back in 1954 checked lactates on 50 to 70 patients, and he found that half of them died with a lactate of 4 inpatient. And then this study was published in JAMA, and it's over 1,200 patients that basically showed that lactate, look at it, In hospitalized 9 ICU patients, non-hypotensive, as well as in critically ill patients, a lactate greater than 4 or 10 to 4 prognosis. So it makes sense that you have what we call a risk stratifier along with lactate to help you. Now, this study was one of the 3 studies, Process, Horizon, and Promise, that people said, you know, this question of whether you should do goal-directed therapy. So they went back and they looked at their data, and they actually looked at lactate. And again, this is over 1,000 patients. And they found that isolated hyperlactemia predicted 90-day mortality, ICU mortality, and hospital mortality in mechanical ventilation. And they went on to say that these observations imply that a lactate greater than 4 is an independent marker of illness severity and can be used for risk stratification to be a candidate for the definition of septic shock. I never thought I'd see the day where they come up and say something like this, but it's true. And the whole idea is 20 years later, we're finally hearing the same thing. So if you go back to your SIRS criteria, and that 1,000 patients we looked at, and you say, what happens with a patient with 2 SIRS and a lactate of 4? 62.5% ICU admission rate from triage. 3 SIRS, lactate of 4, 4 SIRS, lactate of 4. The likelihood of ICU admission at triage. So it tells you it's a very powerful tool with the presence of a suspected infection can help risk stratify your patients. And remember, this is a lactate greater than 4. So when you look at the natural history of sepsis, and you say, if you take them at time 0, which in the past was the ICU, you hook to a monitor, you got nursing, you got residents, fellows, and staff that's looking at you, what's your likelihood of having a cardiac arrest or a hemodynamic compromise is pretty low because somebody's watching you, right? But if you take the same patient and they come in from triage to the ED, and they are in cryptic shock, those patients you never see. And the reason why you don't see them because they die, and they die on the floor. And that's what we call prevention of sudden cardiovascular complications by just screening. And that's one reason why the landscape of sepsis has changed over the years, because we don't allow people to die like that. And so it's important that when you read the literature and you see why one of the natural history of sepsis has changed, simply we've taken them out of the picture. So people who used to go up there and crash and burn and die, just through screening with lactate, that's what's helped us. So if you look at this lady here, she just had a AAA resection, and she comes in with a history of COPD, and she's got an EF of 30%. She says she stopped smoking, that's what she's telling you now. But I want you to see her vital signs. Heart rate, blood pressure is good, right? Heart rate, pulse ox, 100%. I want y'all to remember, because y'all will get a call about her. So
So now I quit today.
Oh, you quit today?
I quit now.
okay, so you got 10 for 39, white count 17,000. Gave us cefepime to Banco because he just left the hospital. And what do you want? What do you want next in terms of your bundle measure? So antibiotics, got cultures, appropriate antibiotics. What have we left out? Lactate is 10. Calling you busy doing a couple cardiac arrests. Oh, this lady down here, she's got a lactate of 10, but she's talking, her blood vital signs are fine. What do you think? What do you think? ICU material? How come? Believe me, it would that's music to my ears because that never occurred before. Before 2000, that was not part of the conversation. So just give you some idea of how we come. Now your lactate is 10, and let's see what happens to the lady, because she stayed in the ER, as a lot of times they do, And this is 30 minutes later, get a little short of breath, and she had to have a line place, and that's her SpO2 is 35. And that's 60 minutes later. And that's an hour later. So if you made a decision and sent her to the floor, what's going to happen? Yeah, she would have coded and died. But the idea is that you intubated her, improved her work of breathing, went to the ICU, and she actually went to F2 after that. And it goes to show you that this is just the nature of well, she made it out of the hospital. But the key point is that is the nature of early risk stratification. So check lactate, use it as one of your methodologies to rule out critical disease. This is a classic example. Okay. Any questions? Mm-hmm. Yep. Bring up a good question. That's the limitation. As you know, every test, whether you do a troponin, there's people who come walk around with elevated troponin. Some of them arrest on you and the troponin is not elevated. That's just the nature of the test. And usually what you see is acidosis, some other organ dysfunction. But alactemia, very common, and that's a flaw. And it just tells you can't be overly dependent on one test. But if it's elevated, it means something. And sometimes it can be over elevated in metformin and what have you, and a lot of other things. But it tells you take a second look at the patient. But you're perfectly right. Clearing your lactate, or somebody who comes in alactemic and got renal failure, and there's something else wrong. And this brings me to the point he's trying to make, is that you have phenotypes. When you look at patients, you don't look at just one number. You look at various numbers, because the combination of all of these cause what we call phenotypic characterization. And there's been multiple studies of lactate using your oxygen extraction, your venous saturation, looking at hyperlactemia and alactemia. And you can see that the combination of these various endpoints gives you different mortalities. These are called phenotype types. And they actually have one for ultrasound now. So you add ultrasound to the background. I didn't want to make a real busy slide, but if you take these ultrasound characterizations of LV and RV function and volume status and add them to these phenotypes, you can come up with some pretty significant risk stratification. But obviously, it requires a lot of detail and attention, but the idea, that's where we're going right now, so we can better characterize clinical trials. Because if you go back to process, arise, and promise, you look at the lactates when we enroll patients in the goal-directed study, our lactates were on the order of 7 and 8. Well, process, arise, and promise, because they had got fluids, they also were enrolled later, and some of them were actually in ICUs, they had lower lactates. And if you look here in terms of your SpO2s, you can see that the SpO2s in the original study was very low, where process, arise, and promise were high because they were resuscitated. And these are phenotypes. And if you were to go back and say, well, I know about phenotypes, and if I classify this phenotype along with this characterization, I know more mortality is higher, is simply a better way to compare clinical trials. Because just looking at randomization and controlled treatment groups without looking at a better phenotypic characterization, the interpretation of these trials can be a lot. So why do you repeat that lactate? Well, you repeat that lactate because it's a good clinical tool. This patient came in with urosepsis, as you can see, modeling of both lower extremities, lactate of 4.6, mildly hypotensive. Got 30 cc's per kg, got a little bit more antibiotics, repeat lactate. You never hear from us in the ER. And that's a lot of times, this is what happens. People don't necessarily go to the unit. They get aggressive treatment. And just by following a simple thing like your lactate and your clinical exam can prevent these people from becoming ICU players later. And this is more, hopefully, the rule than an exception, but it's just one of the examples. And there are studies to show that if your lactate initially is high, and then your repeat lactate is high, your mortality is much higher. And where your initial lactate is low, and then you repeat your lactate and it's high, you can see your mortality is higher. And that's the reason why you want to repeat your lactate, because there are a group of people who lactates may go up. So you may come in 2.5 and you recheck it 3 hours later and it's 6. That patient obviously should be re-triaged, or you got to go back and look at the patient. And so when you look at the measure and it says repeat lactate, that's the reason why you want to recheck the lactate. Shortcomings, we talked about that. Alactemic septic shock, very important to understand. So don't always put all your eggs in one basket when it comes to lactate. This goes to show you what happens if you just do the first 3-hour component of the measure. If you check your lactate, you'll pick up about a 5% mortality reduction. Blood cultures, look at that mortality reduction. And then you talk about timely selection of antibiotics. So when you just do the first 3 things, which we call the 3-hour part of your measure, significant mortality reduction. The next part is a little more complex, but we'll get into that in a second. And that's called the 6-hour shock part of your measure. And I won't take any questions if you have it right now. How we doing? Okay. So when a patient comes in and they're hypotensive and septic shock, they have major hemodynamic perturbations. They can be dry, vasodilated, or they may have myocardial suppression. A lot of these patients haven't eaten or drinking in a couple of days. They just are dry. Some of them have pre-existing disease, EFs of 10, 20%, but in general, combination. In addition, they're febrile, increased metabolic demands, tachypneic, and they also may have what we call microcirculatory or either issues of oxygen utilization in the periphery. So when you get a septic patient, you know, it's not just one simple thing, not just volume, et cetera. You have to make sure that you comprehensively assess the whole patient hemodynamics. And this is what Dr. Bill Shoemaker used to do years ago, where he actually felt that the first 6 hours of resuscitation was so important that you could almost predict organ failure. So he surmised that we need about 140 mils per minute of oxygen. And if that patient came in shock, we created a deficit. And if we repaid it quickly, the patient did fine. But if we let that patient sit around with unpaid debt and we waited even longer, that debt would go from organ failure to lethality or increased mortality. And if we didn't do our jobs, then timely resuscitation was actually deleterious for the patients. So taking this concept, and this was 40 years ago, it makes sense, but for some reason it was controversial. Until Dr. Peter Saffer, promulgated that ICU care should not have borders. When people need it, give it to them. And the issue is that it for some reason, it was controversial to some. So we did a study where we took patients that belonged in an ICU, and obviously we got bed shortages, so that couldn't happen. So we decided to take patients and randomize them to what we call the standards of care back in 1999. So that's when lactate and all that stuff started to become used. And they said fluids, basal pressures, inotropes, check a lactate, get that hematocrit to 30, and check your venous saturation. And that was recommended by the American College of Critical Care Medicine. But we decided to do it early, and we blinded the ICU because they were already in the ER. So we said, well, just do it and send the patients to the unit. So we did it in Cat 1. And that basically was a goal-directed protocol. So simply all the things we talked about, cultures, antibiotics, fluid resuscitation, getting the pressure up, these were all a combination of things we did. And that led to the concept of goal-directed therapy. And what did we do 15 years ago? Well, we made it on TV.
He goes, set up culture. Urosepsis.
What's the antibiotic choice?
Ceftriaxone. Okay, fine. In vitro, ceftriaxone might give you a slightly better gram-negative coverage. Ma'am, how you doing? Ma'am?
So this is a baseline.
And what do you know about early goal-directed therapy of sepsis?
It attempts to balance oxygen delivery with oxygen demand.
And decreases mortality through a multi-pronged approach. She doesn't seem like a candidate for brisk therapy. Well, we need to review her chart. Let's talk to her primary physician. Penny, if we were to pursue goal-directed therapy, where would we start?
Get her BP up.
Right, that's the tip of the iceberg. We want MAP above 65, CDP over 10, urine output over 5 cc an hour, O2 sat above 93, the crit above 30, most importantly, the SDCO2 above 70.
What are you doing with this came out? Running around outside somewhere. But nevertheless, I took you back. The key is, how do you resuscitate? Again, you're going to have multiple lectures on this, and I'm not going to spend a whole lot of time except to say that the tools we have here, you have ultrasound, esophageal Doppler, you have cutaneous oxygen sensor, the Vigileo, you have multiple devices, and even a PA catheter, which I think is the ultimate device. So the idea of resuscitation is based on the tools you use, but the concept of resuscitation, I think, should be the same. Because if you look at, this is my idea of resuscitation. You got a cell in shock, and it's unhappy. And what you want to do is have a happy cell. Now, to get to that happy cell, you got to recognize the cells that are in trouble. So if you're acidotic, high lactate, hypoglycemic, hyperkalemia, these are all manifestations of shock. And as a clinician, you want to risk stratify, be able to take patients who need resuscitation, and you want to have an organized approach. And the first thing you want to do is cardiac optimization. And cardiac optimization begins with adequate preload. You can do that with CVP, wedge pressure, stroke volume variation, IVC. Afterload, obviously, blood pressure, vascular resistance, cardiac contractility, heart rate, and also maintain the coronary perfusion pressure. And then you want to have adequate delivery. And doing that requires an examination of these parameters. And then you want to decrease your consumptive demands if that patient has evidence that they're increasing their oxygen utilization. And then you want to be able to say, how are their cells reacting to the delivery? And that's through looking at your microcirculation. And the reflection of your microcirculation are your endpoints of resuscitation. So along with your other parameters, you want to be checking your venous sat, your lactate, arterial venous CO2 difference, your base deficit pH, even your physical exam. These are all concurrent things that we want to check together. So when you get a patient, there's no one thing that's going to get you through the whole resuscitation. And so when people start arguing you about, oh, I don't believe in CVP, okay. Stroke volume variation, okay, whatever. It's just to say that in your mind, you want to be able to take that patient through a series of maneuvers and we'll call it goal-directed resuscitation. And so in doing that, whatever device you use, be familiar with it, have knowledge, have patient selections, know the right patients for your monitoring, put it on the patients and use them at appropriate timing. You want to interpret the data correctly and be able to do it with expert knowledge. And then you want to be able to transition this to good clinical practice and also successful implementation. So whether you use ultrasound, stroke volume variation, or invasive monitoring, know all the parameters and know what they do and know the limitations of each one. So what do you want to do? The first thing you want to give is fluids. And so fluids are very important because when you go into shock, CNS stimulations, you get a hormonal response. And in addition, you get redistribution of fluids to the central vascular circulation. And what you do is you sacrifice your kidneys, your gut, because you got to make sure that the heart and the brain's getting most oxygen. So when you look at early sepsis care, fluid management is key because patients are hypovolemic. And this came from a lot of animal models. You infuse them with endotoxin, perforate their cecum, or put what they call feces, little pads of feces in the peritoneum. They all go through the same sequence. They drop their pressures, they get hypovolemic, etc. So when you look at early sepsis, the average patient's about 20 to 40 cc's per kg down. And the problem with sepsis is that you get capillary leaks everywhere. And you also get it in the lungs. And that's not something that you're doing to the patient. A bad septic stone goes in the ARDS without any fluids because that permeability leak is so bad. A cholangitis, they go in the ARDS, drop of a hat. They don't have nothing to do with your fluids. But when you give them early and you say, oh, the lungs are crapping out and I got rows and everything, and you think you're doing that, a lot of times it's from the septic. And so when you look at the fluid administration, and you look at the clinical trials, and they say, oh, well, this goal-directed therapy gave so much fluid, and it's been bad. No, if you look at all the clinical trials, Process, Arise, and Promise, and you look at fluid administration, it was all the same. They gave about 5 liters of fluid within the first 6 hours, just like the goal-directed therapy study. So it wasn't about the fluid management. It was about early optimization, but the whole idea of fluid therapy is overblown in septic patients. And I know we're all, conscious about giving volume, but it's just to say that the fluids are a little bit overblown. But we did put in your sepsis EPIC, there is what they call fluid management protocol, or if you're over BMI greater than 30, you can default to what we call normal BMI based on body weight and height, and give that patient 30 cc's based on that. So if you get a patient who weighs 800 pounds, 5'10", then you can actually treat them as a normal body weight and give that sepsis challenge, fluid challenge. But in general, the literature, if you look at all of the different studies out there, there are multiple studies. I mean, we're talking about 30,000 patients on this slide. And then these studies basically showed that patients who didn't get their fluid challenge had an increased rate of mortality, increased ICU admission, delayed hypotension, intubation rates. And it didn't matter if they had heart failure, renal failure, or kidney failure. So, liver failure. So idea of holding back your fluids is not validated in the literature. And if you look at this study, this came out of the process trial, they took patients with end-stage renal disease, and they looked at the fluid challenge in that patient population to see if intubation rates and mortality was different. And what they showed is that patients who had end-stage renal disease versus patients who didn't. If you look at 90-day mortality, 33%, 30%. Intubation rates, 31%. And what is that? 35%. So idea of renal failure as a precursor to intubation from your 30 cc's per kg is not founded. So it's important to understand that even in renal failure, and this is out of Mayo Clinic, and this is from patients with heart failure, end-stage renal disease, and cirrhosis, intubation rates no different. And then this is out of Cleveland Clinic, for patients who had EFs of less than 30%, the mortality, in-hospital mortality, was actually higher in those patients who didn't get fluids, but their rate of intubation, et cetera, was not increased. So when you meet the criteria of a lactate of 4 and hypotension, that is a cutoff that usually you're sick enough that even if you got renal failure, liver disease, et cetera, you need that fluid bolus. Now we will have what we call an opt-out clause that'll come, and I'm not sure if this is ready yet, so you can tell us it's not ready, but it'll basically reflect the thought that you as a clinician can basically document that this patient is contraindicated to the 30 cc per kg fluid challenge, but it has to be documented in the chart based on echo, et cetera. So there will be an opt-out because there are some people that really, don't want to do it, but the whole idea is you as a clinician feel that it's deleterious to the patient, and upcoming change in your epics will allow for that. Albumin, just a little word about it in sepsis. We do still use it for septic shock. For severe sepsis, no. But for septic shock, mortality reduction is 6%. So in patients with liver disease and renal disease, we do use albumin over crystalloid, especially in the first 6 hours, so that we can decrease pressure requirements as well as decrease fluid requirements. As you know, this study has been touted for a long time, but I want you to look at the fine print in this study and basically show that in septic patients in particular, you got a mortality reduction of about 4% with the use of lactated ringers over normal saline. Vasopressor therapy, again, a necessary evil. There is a study that we're doing that are currently looking at peripheral versus central vasopressor administration. The whole point is that complications from vasopressors do exist, peripheral vasopressors, and this is a patient who had levothea running in his antecubital that infiltrated. And this patient ended up, this became necrosed, as well as this patient had to have that muscle belly resected. And so that was a significant part. But so peripheral vasopressor use, and these are actually two other patients that had infiltration. So very important that you get a central vessel when you have vasopressor, especially for 6 hours or more. Application rate about 3.5%. The key point is that you want to maintain autoregulation because patients in sepsis lose that. So you want to get a number about 65. Couple studies, one out of France and Europe, and this one's out of Cleveland Clinic, and this was actually over 10,000 patients. Basically showed that patients do better with higher blood pressures if they're hypertensive. Overall, there was no difference in patients who kept at means of 85, 75, and 65. But when you looked at patients who had chronic renal failure and also pre-existing hypertension, they did better with higher blood pressures. And actually, you decreased the rate of dialysis if a patient's severely hypertensive who came in septic shock. You ran them at that 70 instead of 65. So there's what we call individual variation in terms of blood pressure. Again, mortality, no overall difference. Getting a little bit about vasopressors. When you get tachycardic, go with one that actually has better alpha agonist activity. Again, you want to avoid tachycardia, but there are a group of patients, bradycardic patients, who may tolerate dopamine. So it's not a terrible drug, although it's gotten a bad name lately. But the goal is to decrease your heart rate because you want to maintain diastolic filling. That's why a lot of people have these mismatch elevations in troponin simply because of the tachycardia. There was an article that was published in JAMA about 6 years ago using beta blockers. And this is an article that used a short-acting beta blocker, landiolol, for the treatment of tachydysrhythmias and sepsis. The study was about 151 patients randomized to beta blockade alone, and they wanted to keep their heart rate below 90, I think it was, 90, 95. And they were able to do this successfully in 23% of patients for 96 hours. And the adverse effects were not that great. But the good thing is it was a mortality reduction. I think the reason why we haven't gone on to using a lot of beta blockers is simply because of the side effects and the longer acting activity. But this is a meta-analysis that basically showed that the use of beta blockers in sepsis was actually much better than I thought. And they carried a significant mortality reduction if you maintain the rate less than 95. Talking about a mortality reduction of almost 18%. So beta blockers may resurge based on the fact that we now have a shorter acting agent that we can give an IV. Yes,
Those were actually on pressures with beta one agonist on board.
That's right.
They were on pressures with beta one agonist.
That was the indication.
So you would use essentially both beta one agonists and blockers.
Yeah, they did it in this study. Yeah, and matter of fact, the requisite was that they had to be on pressors. Now, that group of people who were just tachycardic without any pressor activity, they didn't address that. But they wanted to isolate, the heart rate and vasopressor activity in those group of patients, those septic shock patients. Fluids. Need I say, which one would you rather have? But the whole idea, everybody's fluid crazy because they don't want to give a lot of volume. You can fix this. You can give Lasix, put them on dialysis, but you can't fix that. So the whole idea of fluid overload is such a negative impact on mortality. Yes, I'm a believer, but it reflects underlying disease more than it does iatrogenic contribution, but nevertheless, it's it's a controversy. And so this NIH trial, which is called Clovers, is being done right now, where they're actually giving fluid boluses as minimal as 10 cc's per kg with incremental fluid administration to see if limitation of fluids actually can impact mortality. Now, they're only doing patients that are hypotensive, so they're not dealing with people with lactates greater than 4. So the whole idea of fluid administration early to 30 cc per kg is currently being evaluated. Now, this trial has been going on for like 5 years. They had to stop it because of some ethical issues, but it's just to say that it's still a question, and perhaps, you know, we'll have an answer in a couple of years. So it's currently involved. Now, the whole idea of midodrine, I've seen a lot of people starting to use midodrine as a vasopressor. How many of you use midodrine as a vasopressor? Winning them all. Yeah, there's a study out of Mayo or Cleveland that showed that you could wean people off pressors much quicker. And so I just did a little bit of most recent data, and this one actually showed that midodrine can improve your lactate clearance. So if you put a patient on midodrine that was on pressors, their lactate clearance got better. They came off pressors a little bit quicker. But this led to the idea that perhaps midodrine may be a good way to substitute vasopressors. But this most recent trial, basically the MIDAS trial, not a large trial, but basically looked at 60 patients in both groups and actually put them on midodrine at 20 milligrams Q8 hours during the time they were on pressors. And they basically showed that there was no mortality difference. And actually, the pressor requirements were not much different. So it was a little disappointing, but it's the most recent trial. It's a small trial, and there's currently a large multi-center trial that's being done. But the idea is that the oral absorption of midodrine may be a limiting factor, because when you get a patient in shock, you divert blood flow from the GI tract to other organs. So to rely on an oral agent in patients in shock may be a reason why you're seeing erratic results in these clinical trials. But just to let you know, midodrine perhaps may be there. So I'm gonna go on to talk about, as you know, steroids are in vogue, so we don't have to worry about that. And this study in New England has showed that steroids decrease mortality, so we're still on the right side of that. It actually decreased hospital costs. And vitamin C, thiamine, as well as 3 trials. This is the ACTS trial, vitamins trial, pretty cool. The Victus trial, and this is the one we were involved here at Ford. Actually, we were part of ACTS too. No benefit from the use of the combination therapy. So again, just wanted to bring you up to date with that. And a trial that we're doing here as a similar trial is the use of acetaminophen along with vitamin C. This is an NIH-based trial looking at 900 subjects. I'm going to enroll patients comparing Tylenol with vitamin C in patients in septic shock. Again, this is kind of tying it into the ACTS trials, but the whole idea is that we're going to hopefully find out whether or not it actually works in septic shock as well. Other thing we're doing is with hemofiltration, looking at TLR4, which stimulates endotoxin release. We actually have a dialysis filter that we can actually filter off endotoxin. So we have a current study looking at septic shock patients, and we're randomizing them to standard care versus the filter that based on endotoxin levels to see if that improves mortality. And that's called the Tigers trial. Skip over this. And I'm going to end up by going into our current mortality data from our measure. When we look at Henry Ford in 2001, our mortality was 51% for septic shock. And at the end of the goal-directed study, we reduced that to 30%. And people went nuts. They said, this is impossible. The mortality can't be reduced that much. But since that time, we've actually kept it down. And if we look at what's happened across the country, again, as you saw in that video, the New York State adopted a whole sepsis protocol for the whole state, and then CMS followed. And the current data from New York Hospital, and this is 50,000 patients, by the way, these 2 studies. And these studies actually showed that each part of your bundle, whether it's your 3-hour, 6-hour lactate blood cultures, antibiotics, in addition to your fluid challenge, they all decrease mortality. So when you look at each part of your bundle, the cumulative mortality reduction overall for the study was about 6%. But again, each bundle element had a decrease in mortality. And then this most recent study, this is out of CMS, and this is the first 3/4 of the CMS bundle starting in 2008. It's just published in CHEST, which did a propensity analysis to show that you have a mortality reduction anywhere from 5.67% down to 4.6% in this propensity. Propensities allow you to match patients with a lot of homogeneity to look at a singular factor such as bundle compliance to see if it improves mortality. But this study also did what we call some risk adjusted modeling, which included all patients. And this is interesting because this is patient population. If you look at all patients with sepsis and septic shock, mortality reduction was almost 8%. And if you look at severe sepsis, mortality reduction again, about 7%. And then if you look at septic shock, mortality reduction about 7%. But the disheartening thing is the mortalities are still very high. I mean, our septic shock mortality is still 38%. And the reason why it's high is because our compliance is not great. Across the board, nationally, compliance is about 60%. We vary between that and somewhat a little bit lower. And so even though we have effective therapies, it's important to understand that you got to be compliant in order for your therapies to work. So with that, I conclude that do what you can with what you have, where you are. That's really why we had goal-directed therapy. We had nothing else to do but try to take care of the patients. And Lord knows it turned out to change things a little bit, but it didn't come from rocket science. And with that, I'm gonna let Suzanne give us an overview of our EPIC. How are we doing with time? We're okay? Mhm.
Skip right through them. Yeah. Okay. So good afternoon, everyone. I'm Suzanne Schleck, one of the sepsis coordinators here at Henry Ford, Maine. Richard Bellinger is the other sepsis coordinator. So welcome and thanks for listening. So today I'm going to talk to you a little bit about how to use a computer. I need that. Yeah. A little bit, we're going to talk about sepsis from a quality perspective. So we're going to talk a little bit about the CMS SEP1 CMS core measure, define that a little bit and talk about how that drives our management of care. I'm going to illustrate some of the tools that are available in EPIC that help us meet that core measure, and then explore some documentation tips. Everybody got a little brochure in their bag, and if you didn't get a brochure, go ahead and pick one up on the way out. But everything I'm talking about, or a lot of what I'm talking about, is in that brochure, but this is just to help reinforce some of the things that we want you to take away today. So first of all, we're going to start with core measures. So the first national core measure for sepsis, which is the CMS SEP1 core measure, was initiated in October of 2015. So we've been doing this for a little while. Core measures are national standardized processes, evidence-based best practice, and they're designed to give the right care at the right time. So those are some key things about the CMS SEP1 measure. Hospitals have to report compliance to the Joint Commission as well as CMS. And another thing that I'm not sure that everybody knows, but the core sepsis core measure and many of the core measures from CMS are also publicly reported. So if you go to it's a health compare, hospital compare, you can find our CMS compliance. And I will tell you right now, it says that it's 41%, but we are actually, we've been doing better. We've been getting better because everybody's been listening and engaged in this, which is great. So I believe currently our current numbers are about 50%. So we're going in the right direction. I'd like to continue to do that. One other thing you need to recognize about the core measure is it's an all or nothing
measure and it's time sensitive. So what that means is we have to meet all the bundle compliances, all the bundle elements within timing specifications. And I'll get into that a little bit more. But so there's 8 elements that we need to pass. If we fail one, we fail the whole measure. If your antibiotics are 1 minute late, we fail the whole measure. So it's pretty important that we stay compliant. So the step 1 bundle, early recognition and treatment are important. We need to identify, recognize sepsis. So recognize when you have 2 SIRS, identify quickly if you have a suspected or a confirmed infection present, and then determine if there's an end organ. Then you want to hurry up and get that treatment going. So what are the treatment? I think Dr. Rivers already covered some of it, those 3 and 6 hour bundle elements. So the 3-hour bundle elements, these are the things that need to be done within 3 hours of sepsis time 0. I'll talk a little bit more about sepsis time 0, but we can just think about that right now as time of presentation, okay? So you need to get that stat lactate level. Dr. Rivers talked about that. Blood cultures prior to antibiotics. So always make sure that you order blood cultures before the antibiotics, just so everybody's on the same page. And then start those broad spectrum antibiotics as quickly as possible. And then that IV 30 ml per kg fluid bolus, that's for patients with hypotension or an initial lactate greater than or equal to 4. It's to be started within 3 hours of sepsis presentation as well. The 6-hour bundle elements, I might need to stop that. Anything. I can just click next and then we'll go to where I'm going. There. 6-hour bundle elements. So that's going to be repeating your lactate within 6 hours of sepsis time 0 if your initial is greater than 2. Check your 2 BPs. This is to assess for persistent hypotension. So I like to refer to the 6-hour bundle elements as reassessment. So you've done the first part. Now let's go back, take a peek at the patient and see what's going on with the patient. So these are your reassessment. So after the fluid bolus is complete, the nurse should document 2 blood pressures within 1 hour of the completion time of the bolus. And that's, again, to assess for persistent hypotension. Because if the patient has persistent hypotension, what does the patient need? Vasopressors, right? And then the other thing that has to be completed by the time the 6 hours is up is a reassessment note. The reassessment note covers that bundle requirement of reassessment for fluid responsiveness and tissue perfusion. It's inside of your documentation. It's a form, and I'll show it to you in a few minutes. So Dr. Rivers touched on this. You can see there's a few common names on this research. And what this research showed, I think, this is just a brief overview of it. And again, Dr. Rivers touched on it, so I'm just going to breeze right by it. I think the biggest takeaway from this is I'm saying that if we do these bundle elements, if we give these patients this timely treatment, we're going to improve our SEP1 core measure, right? We're going to do better in our measures. But what this shows you is the most important thing is we actually will change the patient's outcome. We're going to give them reduced mortality. They're going to do better, their morbidities. We also have on the dashboard, they don't stay as long. So that's a big difference for the patients. If we meet these bundle elements, if we're compliant with the SEP1 measure, our patients do better. And I always say, let's do this right, because we should get credit for everything we've done right. Well, so we at Henry Ford Health System have implemented a few tools that will help pass the measure. The first one I'm going to talk about is the severe sepsis septic shock best practice alert. I'm going to say from here on out, BPA. Has everybody seen this BPA? So one thing I'm going to share with you about this BPA is it's intended to help, okay? So keep that in mind. It facilitates early recognition and it promotes early treatment. So it's intended to help you. It will alert the first time that the patient has 2 of 4 SIRS and an end organ within 6 hours. It might be less than 6 hours, but generally within 6 hours. So as I said, the BPA is intended to help. It's also intended to alert you that the patient needs your attention. So it demands your attention because it's trying to get your attention. So it's going to keep on alerting until you respond in some way. You either acknowledge it or you state that you're going to do an action. So some of the ways that you might respond is if your patient doesn't have any signs or symptoms of sepsis, then you would respond as no suspicion of sepsis. If your patient is already on antibiotics, blood cultures were done within 24 hours, your patient's already been treated, maybe someone had already implemented or initiated a sepsis alert, you could click currently being treated for sepsis. If you're not providing patient care, those would be those instances when you went into a chart or maybe you're a consulting service and click not providing patient care. But if your patient meets criteria, if this BPA alerts you and you believe your patient might be septic, please activate a code sepsis. So you would push that button on the bottom. So as I stated, if you believe the patient has sepsis, activate code sepsis. If this alerts, I'm going to share this with you. I'm going to stop myself. When we studied this BPA, the sepsis coordinators, we found that 75% of the time, if the patient had a suspected infection or presence of an infection, 2 SIRS and an end organ, 75% of the time, this BPA would alert the provider or the nurse within 30 minutes of time 0. So if it goes off, ask yourself, could this be sepsis? And then activate the code sepsis. Has anybody ever activated a code sepsis? Do you work in the ICU or the GP? In the ER? Okay. Anybody else? Super. That's great. So when you activated the code sepsis, did you push activate code sepsis? That's okay. So I'm asking that because sometimes there's a little confusion that if you push activate code sepsis, something's going to happen. And I'm sharing with you, nothing's going to happen. It's going to make the BPA stop alarming. It's going to let us as the sepsis coordinators and the abstractor groups who go through the records, us know that we're starting sepsis care. But to get the sepsis team to the bedside, you have to do more than push the button. So push the button. And then if you're in the ER, you have to overhead page sepsis alert to whatever room you're in. And the sepsis team will come. And generally in the ER, that's the nurse, sometimes the clinical coordinator, a resident or a mid-level, and staff is supposed to come. In the GPU, which they have, again, push the button, it's not going to make a difference, but someone's going to call 111 and notify the operator that there is a sepsis alert in F2 room 220. So that lets the sepsis response team know that you guys need help and sepsis care. The sepsis response team in the GPU is the rapid response team, the IV team, the patient care team, so the nurse and the doctor. In the ICU, it's a little bit different. Has anybody ever called a sepsis alert in the ICU? So yeah, so it's different, right? Generally, it's sepsis alert. It's a conversation at the bedside between the clinician and the nurse. I would suggest, even if it's not a formalized process in the ICU, still say it or go to the nurse and say, we're going to call a sepsis alert, just to promote that communication so everybody realizes that the patient has timing specifications related to their care. And so that, when you order that second lactate that you ordered the first one 3 hours ago, the nurse recognizes that, oh, this is why we're doing this, instead of going, oh my God, I just ordered a lactate, right? Because that happens. So just to improve communication. The other thing, so the other thing you're going to do when you get this sepsis alert, this BPA, is you can open the order set. So the reason why we're driving you to the order set is because that helps improve our compliance. And we'll talk about that in a second too. You can open it here, or you can use the sepsis order set from your managed orders. Has anybody used the sepsis order set? Super. Anybody else? No? You have used it? Perfect. So there's two sets of order sets. One is the ED order set, or it's a quick list. So if you work in the emergency department, you might be more familiar with the sepsis quick list. And then in the inpatient or in the ER, there's the severe sepsis septic shock order set, and that's what it's called. Both are ways to make sure that you order all of your initial septic workup labs and medications. This is an example of what the ED sepsis order set looks like. I'm going to kind of breeze through this one because I think most of the people in the room are IPD. Is that correct? So I'm going to go to that. So this is what the order set in IPD looks like. And there's a couple of things I want to point out. So when you first open it, please be mindful that many of the things are pre-selected. So if you ordered your CBC 4 hours ago, you just got your lab results 2 hours ago, you probably won't need to reorder the CBC, so you can unclick that. The other things that I want to point out on the order set are the lactate ×2 order and the sepsis bolus order. So the lactate ×2 will give you your first lactate order now, and then it will auto-populate an order for your lactate within 3 hours. And what's really great about that is it eliminates that need for you to have to remember to go back within those timing specifications and reorder. Again, it's also useful communication with the nurse. 30 cc's per kg fluid bolus order. I've got that deserves its own space. But the one thing that we can think about with that one, if the patient's weight and height are in the records, it will auto calculate how much fluid your patient needs. And it will also account for patients with a BMI greater than 30 and auto calculate by ideal body weight. So there's a lot of advantages to using this order. And like I said, I'm going to talk about it a little bit more. The other thing when you use the sepsis order set helps is it helps communicate with the pharmacy that your patient has sepsis and you need your antibiotics quickly, because it automatically orders the patient's first dose for sepsis antibiotic. So those are some advantages. Here's the sepsis fluid bolus. I think we talked about that quite a bit. It's required for patients with hypotension and or a lactate greater than or equal to 4, crystalloid fluids. What I want to share is to try and use this 30 ml per kg fluid bolus order that I showed you that was in the sepsis order set. I believe there's actually an individual order set for the 30 ml per kg fluid bolus. And the reason is there's a lot of things that are connected to it that help us provide best patient care and help us pass the CMS measure. For example, like I said, it accounts for those BMIs, those patients with BMI greater than 30. It'll auto calculate using your ideal body weight. So if you have those patients that are 110 kilos and you think, oh my gosh, I have to give them over 3 liters. If their BMI is greater than 30, you can see that they won't get 3 liters. Okay, so that's helpful. It also prompts reminders for the nurse and the clinicians to do their reassessment elements. So using this order will give you a BPA reminder that you have to do your reassessment note. So don't ignore that reassessment prompt. It's there to help you remember. And then it also will give a reminder to the nurses to repeat those blood pressures. Any questions? So I think Dr. Rivers touched on this a little bit. There will be a Sepsis Dot Phrase that will help you when you have patients who have those end-stage renal or advanced CHF patients that you might be uncomfortable with giving 30 mLs per kg. There's a Sepsis Dot Phrase coming out. The reason that we're putting it on a Sepsis Dot Phrase because to continue to pass the measure, the documentation requirements are very specific. So your patient's advanced CHF and end-stage renal, very specific. So We're going to put a dot phrase out. We'll let you know when it comes out. But keep in mind that best practice continues to be to give your patients 30 mLs per kg. Okay. And then just remember that not all your patients need the 30 mLs per kg, just your patients who have a lactate greater than or equal to 4 or hypotension. Any questions with that? Super. So this is the sepsis reassessment note that I was talking about a little while ago. It is required. It is required for patients with septic shock within 6 hours of sepsis time of presentation. And again, that using that 30 ml per kg fluid bolus order will help you remember to do this because it will send you a BPA reminder. I've said sepsis time 0 and sepsis time of presentation more than once. So just a little bit of knowledge of how we determine that, and something that I'm hoping that will help you as you move forward. So severe sepsis or septic shock is present when the patient meets all 3 criteria within 6 hours of each other. The 3 criteria are suspected or confirmed infection, at least 2 of the 4 SIRS, and then end organ dysfunction. Or, there's the big or the clinician states severe sepsis or septic shock in their notes. So that might be in your differential or anywhere in your notes. And what's the biggest problem is whichever of these occur first. So when you state severe sepsis or septic shock in your notes, it's important that you put a timestamp with it, because without a timestamp, whatever time you open your note becomes time 0. So a lot of times our time 0 will be before the patient meets clinical criteria simply because of timing of note. So keep that in mind as you go forward. So as I said, what you state in your notes is important. It can determine time of presentation. Use timestamps in your documentation. I always tell everybody to try that dot now before you put a statement of severe sepsis or septic shock in your notes. And then if you put that in your notes, say as a differential, and then you've done the lab work and your patient's lactate is 1.8 and your patient doesn't become hypotensive, and you put severe sepsis or septic shock in your notes, and you determined after the workup that the patient doesn't have that, you can always use a disqualifier and state unlikely or ruled out or doubt, and that will negate your statements. Does that all make sense? Okay. There are already some dot phrases out for sepsis. Has anybody used them or familiar with them? Yay, I love this. Okay. So one of them is dot sepsis time 0. So this is to be used when you identify that your patient has sepsis. And what I love about it is it helps you identify, does your patient have sepsis only, severe sepsis, or septic shock? It gives you the definitions, the CMS definitions, to help you determine where your patient meets. The other one we have is a no sepsis dot phrase. And so this is one that we'd like you to use when, so let's say that BPA alerts you that your patient has 2 SIRS and an end organ, and you determine that, or you decide your patient you're not suspecting sepsis. Maybe your patient has end-stage liver disease, or even trauma patients often trigger those alerts. You can use this no sepsis dot phrase to state that the signs and symptoms are not related to an infectious process, and that it will exclude that patient from the CMS measure. Does that all make sense? So that's a very helpful one. Any questions? So just to summarize, the severe sepsis BPA is a helpful tool. It intends for early recognition and early treatment. The Sepsis Alert process, actually, I don't know, Dr. Rivers, did you discuss that? In literature, as well as here at Henry Ford Hospital, we have found that using this process actually improves our SEP1 compliance and patient outcomes. Yep. And then try and use the Sepsis Order Set first to place your orders, because then it helps eliminate those those errors of omission, things that maybe you thought that you had ordered, but hadn't ordered yet. And then the 30 ml per kg fluid bolus order has a lot of things attached to it just to help pass the measure and help you remember to do your reassessment things. Documentation, use the sepsis ×0 dot phrase when you recognize that your patient has sepsis, severe sepsis, or septic shock. And then in your notes, it's really helpful if you use timestamps. And I'm going to add to this because oftentimes when we review charts, we will see things like ultrasound IVC, but if it's just in a body of a note and there's no timestamp associated with it, if that was documented before the fluid bolus was given, we can't use it. So timestamps are really helpful in identification as well as sepsis care and reassessment. And then also don't forget that no sepsis dot phrase to use it, and other disqualifiers. Those are in your pamphlets too, all of those words, because I certainly don't expect you to remember them. And then one more thing, Richard and I review cases of patients that meet criteria for severe sepsis or septic shock. So you may get feedback letters from us. They don't intend to criticize. They only intend to help and to give you feedback just to let you know how you're doing. Okay? Any questions? Nothing? Any other questions for Dr. Rivers? We actually have a few minutes. I know. Yes. That's why I was saying out there. Check the Bluetooth thing. I have more tabs. No, I can stop. Okay. Thank you.
You put a couple of things, guys, so Dr. Rivers is gonna pull some names and then you can come in and take whatever you want up here. So we got a couple of t-shirts, a couple of bags, and a cap. Unfortunately, some of our stuff from the table is here.
Well, they put the names here.
Yeah, we'll watch. Go ahead and pick some names and then.
So if you see anyone in the sepsis chat, you might want to ask.
Nadia?
Nadia? They're gone?
Bethany?
Bethany, there we go.
Come on down. And, Sharon?
Small, medium.
Okay, where's the medium?
Right here. There you go.
All right, congratulations.
That's it. Somebody must grab the shirt, the two caps, and
Okay.
keep going.
Oh,
We got
okay.
3 more prizes. So we got a couple of bags. Let's see. They took it. They took some stuff. So all we got is a small shirt, cap, and then a couple of bags. Whatever you want. Take the shirt.
Michael Graham?
All right.
I mean,
I know you wanted it. I know you wanted it.
Sherry.
Sherry, we're now.
Sherry,
Uh-huh.
you're red.
We got one more to go.
Yeah, one more.
One more.
Washington Dean. She left?
Yeah.
Oh, did he? Uh-oh. Let's go one more. So Hop, you allow me?
There he is. Yeah. Thanks, guys. Thank you. Somebody took them. Somebody stole them out of the hallway. Yeah.
Thank you.
Thanks, man. For helping out.
Of course, of course. Thank you, Dr. Rivers.
Oh, no,
Always-
thank you
always a
for
pleasure.
your patience. And
Yeah, no worries.
Mhm.
For ya.
They hear it all? They hear it okay out there?
They, from what I was told, that nobody called me or texted me saying that they couldn't hear, so